Please do, doctor.
So in CVS, you will get, you see, mostly two cases are very famous. One, it may be VSD, and though it can be anything, but most probably VSD, and another can be post-operative. Please mute yourself. This is my only requirement from all of you. Please mute yourself because lot of background noises. Another is post-operative case. So these are two post-operative. So VSD definitely what is the difference? If it is post-operative, most common case is cyanotic heart disease. So maybe in top is the top. Okay. So but don't get biased in the exam. This is top, right? So
Top with residual PS.
when there is VSD, this is a cyanotic heart disease. So definitely, what is sorry, I will try. I'm not a ma'am. Amar. Okay. Uh, so VSD when the child will be like having no clubbing, no cyanosis, but the child may be malnourished if it is a, and definitely in the exam you will find a grown up child, most 99% that will be like 6 years, 7 years old, because the child can sit over there or can sleep in the lap of the mother, right? If it is a small child, then he is not able to stand still, so he will go here and there. So that's why in the exam they will keep a child who is grown up, like maybe 7 years, 8 years old. So if it is 7 to 8 years old, 9 years old child with VSD, so you won't see any clubbing cyanosis, and he may not be so malnourished, because if it is a large VSD, he must have been operated earlier. Now it is not a large VSD; it may be mild to moderate, which is not healed, or right. So and large VSD, definitely child will be in heart failure if he is not on medication. So mild to moderate, most probably. If it is mild, then also they will not won't give, because it is difficult to assess in mild. So chances are that you will have moderate, mild to moderate, or moderate VSD. If the child is having clubbing or cyanosis, my child is and the scar is there, median sternum scar or natal drain scar. Please mute lot of background scratch noises. That is actually annoying. If you have background noise, please mute yourself.
Make some co-host so that you
Actually,
will be keep muting.
here I cannot make actually. This is actually not a paid Zoom. That cost is available in paid Zoom meetings only. Okay, so I will mute the Amar and co. Okay. So when I want to speak up, you can open your mic. That will be good. Formula 10. Sorry, I'm muting you. Okay, thank you. So as I said, cyanosis, clubbing, yes, median sternum scar will be there. And you have to describe the scar also, that this scar looks fresh, old, pink. So this how it looks, how what is the size, it is from the like from above the full sternum or like this. So you can mention the size around approximately, it looks like 10 centimeter or 5 inches or 2 inches like this. Then right or left lateral thoracoid scar will be there. Usually this in top operated cases you will find it is on the right side, most of the cases. Then they can ask you in the exam that what is the differential diagnosis of this lateral thoracoid scar like this. So you have to tell all other causes of like top repeated tracheostomy fistula repair, lung abscess, lobectomy, right? If it is on left side, then PDA, COA repair, or it can be lobectomy also, or diaphragmatic hernia, everything. So that differential diagnosis you have to keep in your mind. Median student. So what happens? Okay, we will. This is the just rough outline. What cases may be there. So we will go for the CVS examination, how to do in the exam, and each and every step is very important, because UK examiners, they are very keen for the systemic examination. Systemic means they want step by step in a correct way. If you go haphazardly, then they will deduct the marks. So let me clean this. So first, whenever we CVS examination, when we go and we enter the room, introduce yourself to the examiner, or you can greet the examiner. and give your sheet to the examiner, then he will give the command, and he will say, for example, he is 5 years old, Mohan or something, like Marshall Graham, please do cardiovascular examination. Like this will be the statement. You will say thank you. You have already given your sheet. Just wash your hands, which is given on the table. His dog examiner's table. So just take the gel in your hand, look at the child, smile, and take the permission from parents. I would like to examine Graham. Is it okay to you? And give a big smile to the parents. All they will see, yeah, of course. And then by that time you are looking at the child also, and then say hello to the child, give a smile. Then if it is a grown-up child, you have to tell him that I will do examination. And don't take permission from the child, right? Just say that I will do exam. If you find any difficulty or discomfort, let me know. Then give it again smile. And if it is small child, you are a good boy or like this. So that is a reputation repo. So by doing
Recording in progress.
so when you are doing this thing, then you have to see, is there any surroundings are there for DMS, right? So different people have different formulas. My formula was 4DMS. So what you will see in 4DMS, one thing is devices, right?
Dimorphism. Yes, devices.
Devices. So devices, what will you see in the devices?
Oxygen mask or nasal cannula, NG.
Hmm.
CVP line or any central line.
Yes, excellent. So these things you will see in the surrounding
Okay, filter.
that you should not miss in the surrounding. Sometimes that may be a pulse ox, or you can say pulse oximeter, right? That will not be possible in the exam, but still we have to be very careful. So for the vitals, there may be pulse oximeter. Sometimes it is kept, just kept. It is not connected to the patient, but it is kept near the patient. So don't forget that. Devices. So you see the child. So what you will see in the child? Another neck.
Dysmorphism.
If there dysmorphism,
Very good, excellent. So dysmorphic features you are seeing at the face, right? So what
yes.
kind of diagnosis is going in your mind by looking at the face in CVS?
Down syndrome, Turner syndrome,
William.
William, yes, William.
Yes, teachers.
Marfan, Ehlers-Danlos,
Yes, Noonan syndrome, right?
yes.
Allegedly, if you are in UK, most of it can be allegedly, right? So I think you all know how to differentiate between these syndromes, right? So most probably most common is Williams syndrome, right? So Williams syndrome, you will see the child is smiling, talking, like he very talkative child, happy chatters, party chatters, then widely open mouth, serrated teeth, widely separated teeth, full cheeks will be there. So when you see the photo, typically it is Williams syndrome, but you should see types of Williams syndrome.
Dr. Pankaj,
Right?
should always Williams syndrome to be submental, or sometimes they have good IQ?
See, let me mute actually lot of better. Usually, usually such children are submental. But when you see the child, he is smiling, right? So you won't feel that he is submental, but definitely they will be submental. And you can understand a normal child is smiling and a submental child is smiling. There will be definitely difference. You can understand. So they will be submental. But it depends. Some children may have mild MR, some children moderate, mild to moderate. Good. You got my point. They won't be normal.
Yes.
So dysmorphic we understood, and Noonan syndrome you will see that the drooping of eyelids will be there, right? And the posterior ears will be posterior rotated, prominent ears will be there. So that you won't see in the Turner syndrome, right? Over the face. Noonan syndrome and Turner syndrome, you have to differentiate like this. Then our other
Sorry for interrupting. The difference that you clinically told us between Noonan and Turner was one, the drooping of eyelids, and second.
droop, posterior rotated ears, prominent ears.
Okay.
That is in
Thanks.
Noonan, right? So one or two or more, that like there may be this smooth groove, I think, or the this
Depressed nasal bridge in Noonan.
yeah. So these are the
If you
two
can.
which I will always remember, like drooping of eyelids and posterior rotated prominent ear, just like you see in the got, or that you see in the got, or you can say that what we call a ship. Prominent ears are there, right? In got, I think. So like that you remember. And Noonan syndrome, you should see that sometimes there may be bruises or bleeding out in the skin because of that valvular disease. So that also you have to see. DiGeorge syndrome, yes, DiGeorge. So DiGeorge syndrome, what are the characteristics of DiGeorge syndrome? How will you understand? Usually it is not asked in the exam. DiGeorge has never been asked, I think. Williams is very common. So DiGeorge, what kind of things you are looking? What features?
Cleft umbilic.
Sorry?
Cleft lip umbilic.
Yes, yes, excellent. So it may be repaired, right? Repaired cleft lip. And if you ask the to open the mouth,
Locet ear.
lowset ear, yes. Okay, the elfin faces is seen in which? DiGeorge, or it is in Williams? Elfin faces?
William.
William, elfin ears, yes, elfin face, William. George, because there will be affected the branchial branch, so they will have a small mandible. Okay, and they will have a seizure, maybe hypocalcemic seizure due to parathyroid hormone. And they most probably, what we call it, conotruncal defect, part of it, tetralogy of Fallot, truncus arteriosus, and ASD, part of it, I think.
Excellent. But hypocalcemic seizures we won't see in the exam, like clinical stations, but that can be asked to you. What are the complications, right? So that you need to remember.
Yes, vertebral defect, genitourinary defect.
Yes.
Yes, and lower limb defect.
Yes, so thymic hypoplasia is very common because they have immune deficiencies. So they will, what the treatments, or like immunoglobulin replacement is to be given to such children, right? Because they have recurrent cough, cold, and all. Yeah.
But thymic dysplasia would not be like physically evident, right, sir?
Thymic dysplasia, no, but they will ask in the theory what I mean. So
Okay.
yeah, so sometimes the X-ray will be kept. You can say that one X-ray will be kept there, and then they can ask you what you see in the X-ray. I see. So thymic replacement, please mute yourself. I request, please. Those who have background noises, always please mute. And I request. Okay, thank you. Dr. Inayatullah, please, your background noises. Inayat. So, sometimes thymic replacement, thymus replacement is also there, but that is seen in myasthenia gravis. So we see that in myasthenia gravis patients, thymic hypoplasia or thymic regression, you can say. So such patient require thymus replacement or transplant, but that is 70% effective. So that is just theoretical part. Now we were going dysmorphic features. Any other question you have regarding dysmorphic features? How to recognize Down syndrome? You all know, right? Down syndrome, upslanting of the parabollar fascia means this is, eyes. Many people are not knowing. This is the eye, right eye. This is left eye, right? So this is, you can say, normal, but in the Down syndrome it will be like this, But though, what my personal experience is, when I see any normal child in my clinic or in the hospital, many patients are having little upslanting, mild upslanting. So don't get confused this, but definitely in the exam, if it is Down syndrome, then see depressed nasal bridge will be there. And then posterior around downset ears will be there. And mental retardation. All these features will take you to the Down syndrome.
Medial epicanthal fold.
Yes, medial epicanthal fold. So this is, you see, distance will be more, and this is prominent, right? So what I feel, whenever Down syndrome patient is there, when you look at the child, you will understand this is Down syndrome. If you have not seen any time in your clinical practice, then you can see the few pictures in the Google. So it will be clear to you. So this is regarding Down dysmorphic features. Then next is
The dimensions, height, weight,
dimensions, right? So,
height, weight, head circumference.
yes, so if it is a other station or a chronic condition, then definitely in India, Hyderabad exam, there was a short stature. So here your dysmorphic features, and then you will see the dimension. So here it is not in exam, very, very rare. They will ask you to measure the height and weight head circumference because you don't have time, right? Because they will give the measuring tape and then you will ask the child to stand or on the corner and then you will take it is not possible. So I have never heard that the examiner asked you, but you should know how to measure the height and weight, height, weight, and head circumference. So okay. Though I will tell you how to measure if it is there. Usually in so when it is tall stature or short stature, we should know how to measure. So what will you do? You suppose this is a corner of the room. This is corner. So here, this is a wall and this is a triangle, right? So the child is standing here. Okay. Sorry, here the child is standing. And you will measure his, sometime measuring this, so stadiometer will be there. Stadiometer means it is fitted in the wall. So you just pull down this and see what is the height. So this is the most common method, right? So after this, if you want sitting height, then you ask the child to sit over the carpet should be there. He should not sit on the floor. He is sitting on the carpet, then measure his height while sitting. So this is called sitting height and this is called standing height. If you want to measure the in tall stature, then ask him to spread the hands. He will spread one hand. It should touch, middle finger should touch to the tip of the middle finger to the wall, corner of the wall, and then another hand like this, suppose this side. So now we will measure total, what is the arm span. So this is how we measure arm span. This is standing height and sitting height I mentioned you. So this ratio is very important in short stature, proportional, disproportionate short stature. But that
Can you repeat the arm span? How can I measure it, please?
Okay, one second.
If you please.
Yes, yes. So just imagine this is the wall corner of the room, right? So one wall is coming towards me and another wall is like this. Okay, so child is standing here. So his one hand, like left, for example, left hand is middle finger, tip of the finger touching here, corner. He will stand like this. And then another hand is going like this. Okay, so now you can mark here. Now ask him to come to another side and then measure this total length. This is called arm span, which is very useful in tall stature or Marfan syndrome. Okay.
Yes, thank you.
Got it? So that is arm span. And sitting height, standing height, you what? We measure from pubic symphysis to the foot. That is not possible in the exam. So because we need to ask the patient to remove his trouser and all. So that is not sufficient, it's not feasible. But
Can we take sitting height?
sorry,
Sitting height.
sitting height when I asked, just now I mentioned, once you become the standing height, then ask him to sit. And when he is sitting, suppose he is sitting like this, then measure the height from here. So that will be sitting height. So just deduct from the total height sitting height.
Dr. Zoya, please mute. Dr. Zoya.
If you all agree, then we should.
Higher sitting height, the child will sit on thighs, or he will sit on buttocks.
Seat on the buttock. He will sit on the buttocks on the carpet should be there, not on the floor. Small, very thin carpet, and that he will sit on the buttock. Okay.
Assalamu alaikum.
Yes.
Hello.
Yes, yes. Yes, Dr. Inayan.
No, not me.
Okay. So this was the dimensions. Head circumference is very important in CNS cases, especially, right? Remember, in CNS,
Sir, sorry
in
for
CNS,
interrupting.
yes,
Again.
yes, please.
Sir, the sitting height, actually there was so much disturbance. I didn't get how to measure the sitting height.
Yes, first you will check the standing height, okay, and then ask the child to sit on the carpet or the floor. Carpet should be there on the floor, mat should be there, and he's sitting on the buttocks, okay.
Okay.
You got my, his buttocks are touching to the ground, and you can say both the knees are also touching to the ground, means just trying to touch, like this.
Okay.
Okay, so this is her sitting height. Okay, so then what I said in dimensions, they will give you sitting height and standing height. Then you need to know the ratio. Suppose she will say, okay, his standing height is like 104 centimeter, and his sitting height is like 50 centimeters. So like this, she will tell you, she or he, examiner. Then you saw this is proportionate, right? I tell you one example. In Hyderabad exam, there was a child, and they said this is my dimensions were given. So there were proportional short stature. Child was 7 years old, very short, just like 3 years, 4 years. So there was no dystrophy features, there was no anemia, but the abdominal distension was there. Only finding were abdominal distension. Child was comfortable, not in distress, no anemia, and lean and thin. So what are the differential diagnosis according to you in such children? Parents were there, they were normal.
Sir, abdominal distension.
Lost is
Yes.
Tall stature. The patient is
loss of weight was there.
Sorry,
Loss of weight was there.
anyone can tell me what he's saying?
Or weight was normal.
Sir, he's asking about weight. Was there like
Weight
weight loss?
weight was, I think, very less. He was low. Weight was, maybe I think it should be around 12 kg, 10 kg.
Maybe this is
glycogen storage.
لا مرفان
One second. Glycogen, there was no moon face, no chubby cheeks. So it was out. No lead, no
Was
hepatomegaly.
there any clubbing?
Sorry,
Clubbing.
clubbing was not there.
Sir, malnutrition. Can be malnutrition.
He was not anemic.
Sir, malnourished.
مرفان or
No skin changes, no hair changes, not malnourished. He was not malnourished. Next.
Nephrotic syndrome.
No, probably there was no edema over the feet or face.
Can you repeat the question, please?
Sorry?
The question, can you repeat it? The hints you.
Okay, so child was around 7 years old. I think that was a male child or female, I don't remember. And then weight is around 10 kg. Just imagine 10 kg. Height was around 7 years old, so it was 95 centimeter. Imagine. And sitting height was around 48. Okay, child were comfortable. Only findings were there is no anemia. Distension of the abdomen was there. No hepatomegaly, no splenomegaly. Buttock vesting was not there. And then there is no signs of renal failure. No edema of the face, leg, no clubbing, no heart disease.
Celiac.
Maybe preterm not
Celiac.
attaining
Celiac.
Achondroplasia.
There was no signs of achondroplasia. Mid-facial hypoplasia was not there. Or no his family history. No clubbing. Then no sign in the hands.
Growth hormone deficiency.
Growth hormone deficiency. Then child should be chubby. Weight should be good. He should be.
Yes, chubby and small.
He should not be lean.
Celiac.
There was no anemia. In celiac anemia,
constipation, maybe constipated.
No, chronic constipation cannot cause as such severely yes.
Anterior pituitary deficiency.
No signs
Anterior
of
pituitary multiple deficiency.
no
neglect.
no CNS signs. Yes, sorry.
Neglection.
Neglect.
Child neglect.
Child neglect, there is no such history.
And
IBD, sir.
IBD, there
Small
maybe
for-
abdominal muscle abnormality.
one candidate answered correctly just now 2 minutes back, and she did not speak much. So
Is
Is it
Small for
preterm?
gestational
Preterm not
age.
attaining.
yes, this is the service, is preterm. So this baby was,
Preterm not attaining weight.
yes, Dr. Abhi.
This one
What's the
maybe
name, sir?
Brown-Bille syndrome.
No, there is no syndrome.
No.
Yes,
Maybe.
baby was born SGA. Dr. Abhi said correctly. So this was the case of baby was born
SGAs.
SGA baby. So growth hormone will not give.
Case of what? Your voice is breaking, Dr. Pankaj.
No.
Large for gestation.
His voice is clear.
Oh, okay. Yeah.
What was the case, Dr. Pankaj?
SGA baby.
Large for
It was a SGA
gestational
baby.
age.
SGA
Pankaj?
baby. SGA.
Small for
Small for gestational age. Preterm baby.
Small for
Yes, yes.
gestational age.
Not preterm. SGA. SGA is the correct word. Not preterm. Okay. Okay. So we were discussing on dysmorphic features. Dimensions. Now next fourth is, this meeting will end in 5 minutes. We will rejoin the same link. Pani piye. Then next is distress, right? So distress, you will see how is the
Distress, yes.
yeah. So
Distress.
there's distress. Whether distress is there or not. Usually in the exam you find child is not in distress, right? So usually 99% cases. Then is average MS. What is M? What is S? M for mentality, right? So if it is a syndromic child, dysmorphic genetic conditions, you should think of mentality. If it is syndromic like it. Then what is the S?
Speech.
Speech, very good. Mentality and speech. Speech is important in CNS cases mainly. Or it is a operated case of cleft lip and palate. So that is speech very important. Apart from this vitals, MS, sometimes you can see MSV. So vitals you should note down here. So you can make a formula 4D MSV. So this is all these things you are doing when you are looking at the child and talking to the parent, talking to the child, like this is during their point permission. It is very easy. The only thing is that I suggest you should not be in stress. Be relaxed, enjoy the life just like him. So if you are in stress, then you will not be able to complete your task in time. So that is very important. And 6 minutes are very small time. You don't know when you enter, when you are out. Right? This is just like what we can say. If something you are putting in the machine, and then immediately it's coming out from the machine, like just like a washing machine or something. So it is like that. So only 5 minutes, exactly 5 minutes are with you when you are doing the examination of the child. Now you already told the child that I will do the examination. So you will go for the general physical examination, right? General physical examination. So general physical, we will start from the first look at 4 MDMS done. Then we will go to the hands. We will ask the child to give both the hands in your hand, right? So both the hands you are looking. You both the hands, right hand and left hand. So what you will see in the hands?
In cardiac case, especially, doctor.
We are talking about CVS only.
Yes, first I will look to the fingers to check for clubbing, cyanosis, capillary refill.
Very nice.
Yes, and I will check for splinter hemorrhage. Yeah, splinter hemorrhage. Yes, and I will see if there is on the Janeway spot, Osler nodes. Yep, and if the creases of palm creases, if it's pale or not, or cyanosis. Okay, so I forget cyanosis of fingers.
Very good. So where you will see about general.
Fourth and fifth metacarpal for Turner.
Very good, excellent. So yes. So where you will see the genuine lesions in the hand, doctor?
With genuine at the palm of the hand, I will see it.
Very good.
And the Osler nodes on the tip of the hand, of the fingers, and it is painful. Top.
Okay, and how it looks, genuine lesions, how it looks like?
Genuine, like hemorrhage, you mean, like bruise
Very
bruise of
good.
blood.
Excellent, excellent, like a bruise. Correct.
Yes.
1 second. No. Okay, just now I am looking at the chat box. Okay. Now you said that is correctly, she said. So we will remember like CPS. Spondylitis CPS. So C is clubbing cyanosis, P for perfusion, and P for pulse. We will check next to this. And here was stigmata of endocarditis, like she says, splinter hemorrhage, oscular node, and genuine lesions. Then scar marks over the hand, recurrent cannulation marks you can see here. So these are the things. And then CPS perfusion, you will see the nails. So you just press the nail and you will see perfusion. Apart from that, someone said that fourth and fifth metacarpals short or not. Then you can see clinodactyly in some cases, like Down syndrome. And you can see the palmar crease in the palmar side, single palmar crease for Down syndrome, right? Or you can say thumb abnormalities like polydactyly, right? Syndactyly. So in other conditions, we will discuss that later on. Syndactyly, polydactyly, all this. So that was in the hand. Now you go to pulse, clubbing.